Oh, great. So I wanted to give some updates on hydroxyurea, the how, the when, the where, the why. So hopefully this will really help understand. Um, Everybody see the slides okay? Okay, nobody's
Yes,
telling
yes.
me. It's like nobody's telling me you can't, so I'm going with it. Because I can't see anybody when I have the slides on. So let's talk a little bit about hydroxyurea. Because I've gotten a lot of questions lately, and hopefully this will help explain a couple of things. Whenever we present, we have to give you some disclosures. I sadly make no money on hydroxyurea. I wish I did. All right, so a quick reminder of hemoglobin. So hemoglobin is actually an incredibly complicated molecule, and it's made of all these chains, alpha chains and beta chains. And it's important because sickle cell disease is actually a beta chain problem, and the alpha chains are usually normal. The job of hemoglobin is to pick up oxygen in the lungs and drop it off in the tissue. It's also important to remember, because it took me a long time to even begin to grasp this, that there is 25 trillion red cells and about, 200 million hemoglobin in each one. This is very hard to conceptualize. I've always pictured hemoglobin as like 10 happy hemoglobin proteins hanging out in a red cell. One of the ways, though, that it's helped me to understand, so that's why I share it with you, is to think of hemoglobin as a bunch of ropes, and that each normal hemoglobin should curl up into its own little like donut space where it does what it's supposed to do and it kind of doesn't bother anybody else. Hemoglobin, where it is, in the case of sickle cell disease, not quite right, doesn't curl up like it's supposed to, and that has to do with chemistry and molecular charges and things that put people to sleep. But when it does that, it makes the ropes literally twist together. They also start grabbing on to the inside of the red blood cell. And I always picture something literally grabbing onto the inside of a bubble. And it's that combination of the hemoglobins twisting together and pulling on the inside of the red cell that physically makes that red cell sickle in the case of sickle cell disease. By pulling on it, it also exposes other areas of the red blood cell membrane that normally aren't exposed, and it makes it stickier. So in the case of, let's say, sickle cell trait, although you have several of these ropes that are abnormal, the fact that there aren't enough of them to get stuck together is why the cell doesn't sickle. However, if you took somebody with sickle cell trait and cut out all of their oxygen completely, then they would have that ability to sickle. So just a way to think about it. My other favorite analogy, and you'll hear me say this repeatedly, is thinking of a red blood cell as a car. It's the best one that I've come up with, and I often use this when I talk about it with patients as well. The job of the car is to drop off its passengers. The job of the red blood cell is to drop off its oxygen. If the parts of the car, specifically, I use the analogy of the tires, aren't right, are wonky, there's better chance that car will wreck. In the case of sickle cell anemia, where all the hemoglobin is now hemoglobin S, all the tires are wanky, right? So there's a better chance that that car doesn't make it where it needs to go and instead ends up dead on side of road, the car, not the people. But then the people get out because they can't get anywhere. So the oxygen never gets where it's going. If there's more traffic, the car and the oxygen don't get where they're going. So the other thing, again, as I mentioned, is to think about how this hemoglobin changes and then bends the red cell when it changes. And this is just a very old school image that shows that. Putting that all together on the right side is what we used to think happened, meaning that we used to understand, and by we, I mean global medical community we, that it was really a red cell problem, that the red blood cells, as you can see, instead of their normal, happy, flexible shape, actually change into this sickle shape and then get stuck. That is all true, but it's way oversimplified because, as you can see on the left, there's not just cars on the road, right? There's trucks, there's motorcycles, there's people, 18-wheelers, garbage trucks. And these all fit into my analogy because the more trucks on the road, the more traffic, the more likely there is to a wreck. Specifically, the more garbage trucks, your macrophages, and 18-wheelers, your neutrophils, that are all there to fight infection and deliver antibiotics and anti-infectious sort of machinery, right? The more those are on the road, the more traffic you have, the more wrecks. In this scenario, the more vaso-occlusive events. So if you actually took somebody with sickle cell disease and got rid of all of their trucks, so you got rid of all of their neutrophils, they will almost never have a vaso-occlusive crisis because it's actually so much dependent on not just those cars, but the trucks that are blocking the traffic, or in this case, the neutrophils. So now putting this into somewhat of a more accurate image, somewhat. This shows you all the different cellular parts within a blood vessel that contribute when we think about vaso-occlusion. Again, it's not just the red blood cells and the sickled cells, but a lot of it has to do with how those macrophages and neutrophils up here in this left-hand corner block the road and stick to the inside of the blood vessel. And when they do that, then the cells get stuck. Rarely will they get stuck in the absence of a white blood cell. In very, very small children who have very small blood vessels, they will get stuck because the blood vessels are so small, right? The road is so small. So when we think about the pediatric, especially young children complications, we think about dactylitis, which is swelling of the hands and feet. And that's because those blood vessels, the capillaries in the hands and feet, are so tiny that even just the cells, the red cells alone, can get stuck. But as you grow and your blood vessels grow with you, you really need all these other sort of elements to get stuck. I'm also bringing up here these selectins, which look like kind of Pac-Mans on the side. There's 3 main types. And this is important when we talk about some other drugs because selectins act as hooks on the inside of the blood vessel, and they're also on platelets and white blood cells to help adhere those cells to the inside of the blood vessel. It's like a hook that hooks those neutrophils, macrophages in, which of course in healthy behavior is so those cells can then get into the body to fight infection. But in abnormal behavior, as in sickle cell disease, it actually acts as hooks to increase your likelihood of vaso-occlusion. We're not talking about it right now, but P-selectin specifically is on endothelial cells, which is the inside of the blood vessel, these cells here, platelets, your little fun guys here, and white blood cells. And P-selectin specifically contributes, we know, to vaso-occlusion, and that's what is blocked with the drug crizanlizumab that we use. All right. The other thing that we know happens is even when there is no vaso-occlusion, even when we know the cells are still freely floating happily through the red cells, the hemoglobin itself inside that red cell doesn't hold its oxygen well, so it's unstable. And that makes it more likely to hemolyze or break apart. Down at the bottom here, you see what happens when that red cell hemolyzes and releases its free heme. In doing that, that free heme soaks up all the available nitric oxide. That's much more complicated and very hard to think about, but nitric oxide helps control when our blood vessels relax and when they contract. And so by being sort of functionally nitric oxide depleted, it's also a problem that people with sickle cell disease will often contract their blood vessels when they're supposed to dilate them. So that also contributes to not getting enough oxygen where it's going. And then finally, the blood vessel itself is damaged, just like the road gets damaged. All this vaso-occlusion, this extra adhesion, as you can imagine, if you again think about a road that never gets repaired, think about a road that constantly has people running into the curb, you can imagine it gets damaged. The more the blood vessel gets damaged, the more adherent it becomes, the more its edges have almost what feels like Velcro. So when you sometimes will hear people say, my pain is always in my legs, that's a combination of 3 different issues. One is the blood vessels of the legs where they've probably had recurrent vaso-occlusive crises are more damaged. The more damaged the blood vessel, the more likely they keep having a crisis in the same area. Number 2, our bodies remember pain really well. And so some of that is just a pain response. It's that when something hurts, the body immediately goes, oh, I know what to do. I know how to sound the alarm. I'm going to sound the alarm in the same place I've always sound the alarm. And so even if the pain is in the legs, it actually may not be where the problem is. And finally, the nerves that get damaged through this process start sending the wrong signals. So sometimes people say, oh, I'm having a crisis in my legs, and you look at their labs or you look at them and you're like, but everything is fine. They feel pain equivalent to an acute pain crisis, but they're not having active vaso-occlusion, which is a talk for another day. And finally, we know that sickle cell disease is a multi-system disease. Every organ in our body, every tissue requires oxygen. So if the problem is oxygen delivery, then of course, every single organ and tissue could be affected. And this is just a great figure that shows that. So now moving on to our topic of interest, hydroxyurea. What does hydroxyurea do? Well, it's actually, we stumbled onto a drug that happens to do three great things in sickle cell disease. The first is that it forces the bone marrow, where our blood is produced, to increase fetal hemoglobin production. Fetal hemoglobin is baby hemoglobin, and I imagine it, and of course this isn't at all what it looks like, but I imagine it as when you go back to here and you think about these ropes, I imagine it is marbles that come in between all these ropes and make it so that the ropes can't clump. That's how I picture it. That is not at all what's real, but it's how I picture it. So that's fetal hemoglobin prevents those ropes from becoming those tight clumps and braids and causing the actual physical change in the cell. But it also prevents that cell from breaking down as easily because it acts as normal hemoglobin. And so fetal hemoglobin, which is made by gamma globin, or is gamma globin, sorry. Remember we talked about normal hemoglobin has beta globins and alpha globins. Well, when you're born, you actually have gamma globin as well. So this causes that gamma globin to be produced. And gamma globin and fetal hemoglobin are the same thing for this purpose of this conversation. But that's not all that it does. So that's pretty great that it causes fetal hemoglobin to be increased. But one of its other key effects in its effect on the bone marrow is it decreases the number of white blood cells. And that's down here where you see its effect on myeloid cells. So it decreases neutrophils and it actually decreases the number of reticulocytes. Reticulocytes are great. They're new, happy red blood cells, except that they're bigger and stickier than a normal red cell. And so too many reticulocytes is not good, which of course is very hard to put in your brain. We need those reticulocytes to make new red cells, but we don't want too many of them. So it's a careful balance. And then finally, it affects the vascular endothelium. And there's a lot of different theories or hypotheses. I don't think we really understand it. I've heard lots of different hypotheses. But suffice to say, it helps that endothelium work better. Some people think the hydroxyurea itself acts as a nitric oxide donor. Some people actually think that because it's just decreasing hemolysis and there's less cells breaking down and less free heme, then there's more nitric oxide. So suffice to say, we don't totally understand it. But it's not just about the fetal hemoglobin. It works in a couple of different ways. Again, how does fetal hemoglobin matter or why does it matter? So on the left, you have hemoglobin S, and remembering that fetal hemoglobin is a different kind of hemoglobin, and so it kind of intersperses within all that sickle hemoglobin so that it can't form those twists or braids. That's one of the reasons that fetal hemoglobin helps. So the original study, you'll hear some of us call it the MSH study. It was a multi-center study of hydroxyurea. It was a double-blind, randomized study, but only people with sickle cell anemia were included, so SS disease and S beta 0. Had about 300 patients in it. When they did this initially, the whole goal was to decrease pain crisis. That was the outcome measure of the study. So they only enrolled people who'd had at least 3 crises or more in the year prior. And they were able to find that hydroxyurea significantly decreased that number of crises. People had 2.5 per year instead of 4.5. That was significant. There was 50% less acute CHES in those people who had hydroxyurea, and a lot less people needed transfusions. So that is the hallmark study from which we prescribe hydroxyurea now. What did we learn? Well, we learned that not only did they actually have decrease in acute pain crisis, but they had decreased acute chest syndrome, decreased numbers of required blood transfusions, and decreased requirements of being in the hospital. The less you're in a hospital, almost always the better you're going to do, right? Hospitals are often not the world's best place to get well, right? Especially if you're in the hospital getting pain medicine, because you're not taking deep breaths. You're increasing your risk of acute chest, but also blood clots. There's an increased risk of infection. If you're not getting as many transfusions, then you're decreasing your risk of all the things transfusions cause risk for. So overall, not only do people who are taking hydroxyurea have fewer of all of these, but they live longer. So this was a mortality study, and it's not 100% causative. And what I mean by that is we know that people who are receiving hydroxyurea here had a better overall survival, and that people not receiving hydroxyurea had less of a survival or were a lot more likely to not survive. The question that we don't know the answer to at this point is this improvement in survival because people weren't in the hospital? Or is it because hydroxyurea preserves tissue and organ function better? And we don't know the answer. So in other words, if hydroxyurea, if everybody took hydroxyurea, but you still had the same number of hospitalizations, would you still have longer survival? Or thinking of it, if nobody was in the hospital, would you still have longer survival? We don't know those answers yet, but we know that hydroxyurea is good for overall survival. There are some side effects. What people complain most of is thinning hair. It's not hair loss, it's as profound as what you see in the setting of chemotherapy that's more systemic, but over time they will get thinner hair. About 1 in 10 people, their fingernail beds turn darker or they'll get some dark spots, hyperpigmentation on their body. They can have nausea or fatigue. Those are side effects that almost always go away when they consistently take the medicine. And there is a lot of concern, and it still exists, that hydroxyurea could increase the risk of cancer. We know that all chemotherapy can increase your risk of cancer because it affects the way that the tissue develops, specifically blood cells. But the doses that we use and the time and experience we've had with hydroxyurea does not suggest that there's any causative analysis that has proven that there's an increased risk of cancer. We don't believe that it could cause a risk of cancer. However, there's a question if you took hydroxyurea and another drug that changes your bone marrow, could that increase your risk? And we don't know the answers yet. However, we also are worried about birth defects. So interestingly, if you give a bunch of rats hydroxyurea, we definitely know that they will have birth defects. But it's at supratherapeutic doses, meaning it's very different than the doses we give to people. So we actually don't know, even though we guess or believe that hydroxyurea could cause birth defects. We haven't totally proven it. Pregnancy studies are very hard because you don't want to risk birth defects. We do know that in rats, it causes absolute birth defects. So that's why we put a black box warning on it and tell people to stop it when they get pregnant. That being said, I've had numerous patients get pregnant with hydroxyurea and not have any children with birth defects, but that's not how you really prove something doesn't cause something. Just ask our government. That's not proof. Proof that we did this and so it didn't happen doesn't prove that if you continue to do it, it won't happen, and vice versa. What we also learned in the last 15 years, though, is that hydroxyurea can significantly lower sperm count. It can cause full azoospermia, meaning men may not produce sperm. This is really important. We didn't know this 20 years ago. And so now as our men are growing up on hydroxyurea and starting to have children, we don't know how many of them may have this issue. In some cases, if you stop the hydroxyurea, sperm production comes back. In some cases, it doesn't. But we do want to make sure if we ever counsel somebody to stop hydroxyurea that we start them on something else, because the risk of stopping hydroxyurea and really causing severe outcomes, pain crisis, acute chest, or death is very high. Most Hydrea, or the classic Hydrea pill that most of our patients take, they'll tell you it's a pink and green pill, but of course there's other generic forms. Usually we tell them to take it just once a day, and that we'll adjust the dose over time, but it takes a while to see a benefit. And that's very hard for a lot of people, and I think that's especially hard in people who are used to taking pain medicine, because pain medicine works right away. And so I think there's an expectation that all medicine should work like that. Hydroxyurea, it takes time to build up that fetal hemoglobin, and it takes time to suppress the white count. And so what we know is that it may take 2 to 3 to 4 or 5 months to see an improvement in how somebody feels. So what are we measuring or monitoring? Why do we get labs with hydroxyurea? Well, as I mentioned, one of the ways it works is by decreasing that white cell count. And so we know that it will cause a decreased white count over time, but we don't want to cause anybody to get infected. So we have to watch both the total white count here at the top, as well as the absolute neutrophil count, because we know that specifically it'll affect that white count and then also the neutrophil count. Interestingly, while hydroxyurea, as you can see here, this is somebody who's been taking it over a couple of months, and it will actually usually increase hemoglobin. That's because those red cells with fetal hemoglobin live longer. If there's less hemolysis, then there's less red cell damage and your hemoglobin goes higher. It's great. In some cases, though, it's a balance between how much the hydroxyurea suppresses the reticulocytes versus stabilizes those red cells. And so sometimes we'll see patients that actually drop their reticulocyte count. We also use the mean corpuscular volume, or MCV, right? All those other numbers of a CBC you don't look at. The MCV tells us how big the cell is. And by looking at that, we can see if people are taking their hydroxyurea. One of the ways it works is by increasing the red cell volume. That goes into far more biochemistry than you wanted this morning. And then, of course, we have to monitor platelet counts because just like it can suppress neutrophils, it can suppress platelet count production. And again, that ANC, or absolute neutrophil count, we have to keep an eye on it because we don't want to increase somebody's risk of infection. So how do we do that? When we first start hydroxyurea, we always check labs monthly. Interestingly, when they did that study I showed you, the MSH study, they actually checked them every 2 weeks, but that would not go well. Many of our patients would not tolerate having to get labs checked every 2 weeks. So we just check them monthly, and we've never had a problem with that. And then once we know they're stable, and every month we will increase that dose a little bit. In children, we're much more aggressive about increasing the dose to what we call max tolerated dose. In adults, it's much harder to maintain individuals at max tolerated dose because of kidney changes and other changes. They're much more likely to get bone marrow suppression. So I'll push the dose till about 30 years of age, and then I'll slowly not push it as far. Once you get to a stable dose, we then check labs every 2 months and then finally every 3 months. And what are we monitoring for? That absolute neutrophil count, less than 1,500. We've slowly gone down on that, but as long as we keep them above 1,500, we have not seen any increased risk of infection. Low hemoglobin. Well, how do you determine if someone's low hemoglobin, which we know can have many causes in sickle cell disease, is from hydroxyurea or not? That's a harder thing to tell. And when do you worry about it? Well, if it's more than a gram below their baseline and their reticulocyte count is low, that tells us that they're not responding to that anemia. So we actually had a patient yesterday I meant to copy and paste her labs into this because she was the perfect example. On hydroxyurea, her normal hemoglobin is about 8. We got her labs yesterday and her hemoglobin was 6.8. And when I saw that, my first thought was, oh, do we need to reduce her hydroxyurea dose? To look at that, I looked at her white blood cell count, which was fine. I looked at her neutrophil count, which was fine. And then I looked at her reticulocytes to ask the question, well, why is she low and is she still making enough cells? Her reticulocyte count had gone up significantly. So that tells me she's responding appropriately. So it's not a hydroxyurea issue. It's probably like she told me she'd had a vaso-occlusive crisis recently. So during that time, she'd had more cell breakdown and she was recovering from it. So all we need to do then is repeat her labs. We don't need to stop her hydroxyurea. Her body is responding appropriately. If the platelets are less than 80,000, we hold the hydroxyurea because we don't want people to bleed. And then the measures of fetal hemoglobin and MCV, those are used for us to measure, are they taking it? Is it effective in a laboratory assessment? So what if you see any of those things? The neutrophil count below 1,500, the white count dropping, the hemoglobin that's more than a gram down, and they're not making cells or their platelets low. So first we hold the medication for 2 to 4 weeks, depending on how low they are. We consider whether a transfusion is needed during that time. And then we repeat the labs. And if they're not improved, we'll repeat again and keep holding. If they are improved, but let's say they were on 2,000 milligrams before we held it, We don't want to immediately restart at that high dose, so we'll usually restart at about 50% of their previous dose and then can slowly increase them. Sometimes they will have had a viral infection or be on certain antibiotics that will decrease your counts. Sometimes they're just not tolerating that hydroxyurea as much. They've gotten older, or their kidneys aren't working as well, and we'll never get back up to that same dose. But we just have to do it slowly and not just hit them at that same high dose. Common mistakes that are made. For a long time, we didn't give enough hydroxyurea. We didn't offer it. We said, oh, you make 10% fetal hemoglobin at baseline. We're not going to give you hydroxyurea. You have S beta plus disease or you have SC. And often individual patients are very concerned. And just so you know, when they get the hydroxyurea in the bottle, it has a skull and crossbones on it and says things on the bottle, don't handle this medication without gloves. So it scares people a lot. So we really try to explain to them that touching this medicine is not going to hurt them, that it's not going to cause a problem on their hands or cause problems in that sense, because the bottle looks scary. The biggest problem I see in the community is that a lot of our community doctors put people on random hydroxyurea doses and then they never monitor them. And so I'll hear we had a couple of patients who said, oh my God, that it were referred to us because they were suddenly transfusion dependent when they weren't before, and they were just on too much hydroxyurea and nobody paid attention. Sometimes we don't let it go long enough. We don't try it for long enough. So the patients will tell us after 2 months, right? It's not working. I don't feel better. I don't want to take this. Or I've seen a doctor say the same thing, and that's too short a trial. And then we often see times when patients are in the hospital and they'll stop their hydroxyurea, and there's no need for that. There's no indication to stop or hold hydroxyurea in the hospital. Any questions? Really? No questions? All made perfect sense.
Can you hear me? Oh,
Yes.
sorry. Yes. Is it ever held like preoperatively?
Great question. Thank you, Callie. Yes. Only usually not pre-op, but post-op, same idea. I will often hold it if they're going to have a large surgery, like a surgery that requires multiple stitches. So the best example is a total hip replacement. Those individuals have an incision that's, 6 inches long, and I'll hold it till that incision is completely healed because it can delay healing. But if they're having a gallbladder surgery or something, where the incisions are really small, then I don't worry about it. But in the setting of a hip specifically, I will hold it till that incision's fully healed.
And then does it take like the full, are they essentially like starting therapy over at that point? Like will it
No,
take
you can
another
restart it at
before
regular
this?
dose.
Okay.
Yeah, you can, because they didn't have suppression, you can just restart them back on whatever dose they were. It's just that if any of us have bone marrow suppression, I mean, if I gave you Bactrim for 2 weeks, your bone marrow would get suppressed. That's one of the side effects of Bactrim. It's why we don't want our patients to take it. In that scenario, though, because your body or our normal bodies only make about 1% new red blood cells a day, no big deal if we don't make cells very much for 14 days. But if in sickle cell disease, where they're making about 10% of their blood volume every single day, you can imagine holding that will cause severe problems. So in the case of something like antibiotics, where their bone marrow has to recover, or a virus, we don't want to start them back at full dose because their bone marrow is still recovering. All right, awesome. Well, I'm actually on my way to present to the ER doctors about how we treat vaso-occlusive crisis or acute pain crisis in the setting of the emergency department. So I'm hoping that I can record that presentation as well, because it's, of course, very similar to what we do in the setting of the infusion area. So I'll be able to share that afterwards also. So thank you much. Have a wonderful Thursday.
Thank you very much.